We talked a little bit about how this is sort of a resurgence. The concept has seen some hype cycles that have fizzled. What's been the problem historically, and how are we kind of overcoming that problem now?
Yeah, I can start here. So,
Sure.
yeah, to start with, of course, the reason why it has fizzled many times is linked to potency. It really simply didn't work. Simply wasn't effective enough. If it had been effective, the side effects then would have been easily to overcome. They were, of course, safe already to start off with. So it was really the link to efficacy, and that had its root in the amount of science that was available and knowledge that was available then. So and also the way developers had to start with really late stage patients. You could only start with patients that had gone through stage first line, second line, and so on therapy. And at the end, you had a stage 4 very advanced cancer with the bulky tumors and multiple metastases to treat. And we know now that, knew already from animal models that vaccines and virotherapies really work best when the tumors are very small. The immune system is doing this all the time, probably in all of us. I don't know now for all of us, but killing off tumors early on, we don't even know about it. So that concept, of course, is something we just augment with these cancer vaccines. So the immune compromised patients was one of the problems. We also didn't have access to rapid sequencing, so we simply couldn't make individual diagnosis or understand mutations. So we couldn't design antigens very wisely. So we stuck to overexpressed proteins and others that really were riddled with self-tolerance. And that approach is not dead. That approach might still work, but I think that in combination with the late stage and also with the weak vaccine platforms that were used, they largely came from the infectious disease vaccine mentality, safety, purity, and potency, but really pure and safe mentality there that probably in retrospect led to underdosing and not fully unleashing the power of what those vaccines had. There was also not enough powerful adjuvants at that time.
Yeah, some good historical context there. Joe or Robert, anything to add there to the sort of response to why things fizzled before and why things are different now?
Yeah, I think obviously Peter summarized this very expertly. Maybe to be a little bit more specific about the type of immune responses that we have induced in the past, I think despite tools seemingly having been optimized for CD8 or cytotoxic T cell responses to be induced, we've often seen that it was actually CD4 T cell responses that were induced more efficiently, and maybe that also comes from the analogies from the infectious disease space. And I think one of the reasons why we now have a resurgence of these technologies is because we have figured out how to better induce CD8 T cell responses that can more directly attack the cancer and kill it off. And that together with then combination regimens that are now available like checkpoints will really sustain that response, which I think to answer one of the questions that's coming in the chat is probably more suited for solid tumors rather than hematological diseases.
Great, thank you, thank you, Johanna, for taking the bull by the horns with that question, Sabu, and thank you for that question. Robert, anything to add there?
Yeah, I think the thing I would reiterate everything that both Peter and Johanna had said. The dosage effect that we see with RNAs are much greater than what's been done in the past with things like DNA vaccines and other vector systems. We're much better able to modulate the immune system now, even with the choice of lipid that we use for in the lipid LNP. But I think even just as importantly, and I hate to say this because I started graduate school in 1994, and my very first project was working at trying to come up with a DNA vaccine for KRAS mutations for pancreatic cancer. And back then we really didn't understand how well a particular epitope would bind to an HLA, and that that project worked great in mice. Didn't work at all when we took it to humans because it turned out that peptide region didn't bind to. There were like 7% of the human population had an HLA that would actually bind that epitope, right? So, especially with the personalized vaccines now, like I was saying before, You know, we're at a point now informatically where we understand even HLA presentation so much better in HLA binding that, you know, we can go and we can actually informatically go and take epitopes from, you know, 30 or 40 different mutated proteins and much better predict which of those we're going to use as neoantigens because they'll actually bind. You know, we can predict what HLA type they'll bind to. You know, with the idea that you really want to bias towards things like HLA-2, you know, which covers 80% of the human population.